Thank you for coming out today. This will be a really fun lecture to listen to. It will be very informative for the weekend warriors out there and the big-time athletes that we have here at Brookhaven Lab. I wanted to introduce Dr. Michael Sileo. He is a orthopedic surgeon here on Long Island at Orthopedic Associates of Long Island. He is board-certified orthopedic surgery and fellowship-trained sports medicine. So if you don't mind, give a round of applause for Dr. Sileo.
Thank you. Is this working? Oh, yeah. Oh, wow. All right, cool. All right, thanks. When Gary introduces this as a fun lecture, I think that's a relative word. It can be as fun or as unfun as I make it. But what I want to do is we're going to give a talk almost like in conjunction. And what I'm going to do is we're going to talk about some of the most common overuse injuries that I see as far as athletes and people who are weekend warriors. And I'm going to talk a lot about the orthopedic part. I'll try not to bore you. If I'm boring you, you got to say something because I will go on for the full hour and not even realize. But I'll try not to bore you with some of the painful details, but hopefully this will be informative enough that you'll kind of pick up a few things and maybe it'll have you leave here with a better understanding of some of the aspects of orthopedic sports medicine that may or may not, hopefully they don't affect your life. And then Gary's going to interject from time to time. We have a handful of slides that are going to talk about on the therapy side, what kinds of things we do to treat some of the conditions that we see. And I've done this lecture a couple times over the last couple of years, and every time I give it, it sort of evolves, and I change things based on the questions I hear and what I find people are most interested in. So you may find an occasional slide on a topic that almost seems like it's off base a little bit, but hopefully it'll make this a little bit more interesting for you. So I am not a terribly formal guy, so if anyone has a question, you can really just shout it out, and you don't have to be embarrassed. So. With all that out of the way, we'll go with the talk itself. And if you kind of look across the medical literature, it's pretty consistent that most experts recommend somewhere between 30 and 60 minutes of exercise a day. We all know about the health benefits of exercise, ranging from as well as stress and mental health benefits. Can you guys still hear me? All right, cool. And really what's interesting is that there's really a benefit to both cardiovascular or endurance activity as well as weight training. It's not that one is better than the other. They're both beneficial. When you talk about cardiovascular or endurance activity, you're going to see a lot of overuse injuries, at least in my practice. They're very common. And sometimes the diagnosis can be sort of a mixed bag. It's going to be a combination of not just history and exam, but imaging and or other tests. And we're going to talk a lot about some of these other tests. I'm going to talk a lot. Yes. Oh, I was all excited. I thought that was my first question, but never mind. All right. So I'm going to talk a lot about stress fractures of the lower extremities, some of the common things that we see. We're going to talk a little bit about something called patellar tendinosis and ITB, or iliotibial band syndrome. Talk a little bit about shin splints, which I'm sure everyone here has heard of. A little bit about something called exertional compartment syndrome, which is truly an orthopedic condition we see quite a bit of. And we'll talk a little bit as well about Achilles tendonitis or tendinopathy, what some of the treatments are. So this is kind of your general outline. One of the things that I think is interesting and kind of a good piece of information to know is that bone is a dynamic organ. It doesn't just sit in your body. It actually works according to what's called Wolff's Law. And basically what that means is your body actually forms bone where it needs it, and it resorbs bone from where it doesn't, okay? And what you have when you have a stress fracture is essentially you'll have a partial or complete injury to the bone due to repeated stress. And there's two types of stress fractures. One is an insufficiency type of stress fracture, which is really when you have normal stress on abnormal bone, unhealthy bone, whether it be rickets or osteomalacia. There are all sorts of different conditions of the bone that can make it more prone to injury with just normal stresses. But really when we talk about stress fractures in this sort of setting, what we're really talking about is a fatigue fracture, which is when you have normal bone but abnormally high stress. And essentially what you have is you have an imbalance between the cells that build bone and the cells that resorb bone inside your body. When you talk about stress fractures, a couple of little bits of information that are interesting is that the tibia or the shin bone is actually the most common bone that's going to be involved with a stress fracture of the lower extremity. Most commonly, you're going to see these kinds of injuries in association with a change in activity or a change in training. Generally, the pain is going to be localized to a particular area. The pain is generally relieved with rest. And a lot of times it's a good history that'll sort of tip me off, at least, that there's something going on, whether it be that an athlete or a runner has recently changed their mileage, they've changed their shoes, they're changing where they're running, they're changing the type of terrain that they run in. So a lot of times it's more the history than the exam or any kind of imaging that leads me down the road of considering stress fractures a possible diagnosis. As far as risk factors for a stress fracture, and this is just general lower extremity risk factors, poor training techniques, and we're going to talk a little bit in more detail about what that means. There are anatomic factors that can predispose athletes or anyone for that matter to stress fractures, whether it be problems with the foot or the lower extremity otherwise. Age obviously is going to be a risk factor. Females, generally speaking, are at higher risk for stress fractures in the lower extremity, and we'll talk a little bit more about why that is as well. On my end, stress fractures are interesting because they are, to me, they're almost more of a history kind of diagnosis than an exam. Sometimes patients will have localized tenderness at where the stress fracture is. Sometimes they'll have what's called a positive percussion test, which basically means if you tap the bone anywhere, the pain localizes to a different spot, which is generally where the stress fracture is. And imaging a lot of times is going to be normal. Most of the time, X-rays will be normal within the first 2, 3, or even 4 weeks. This X-ray is actually an X-ray of a stress fracture about 4 weeks out, and you can actually see the sort of swelling of the bone here. This is what's called callus. This is bone forming at the site of a stress fracture, and one of the most common places we'll see it in the foot. Usually you'll see a stress fracture of the second or third metatarsal. If you get an X-ray right after, most commonly you see this in like a dancer actually, you get a normal X-ray, and then I'll re-image it 3 or 4 weeks later, and you'll start to see bone forming there. It almost confirms what you think is going on. Sometimes you'll see soft tissue swelling, subtle thickening in the bone. Rarely you'll see a fracture line. And a lot of times when the clinical suspicion is high, we'll end up doing further imaging other than an X-ray. And that can mean a couple of different things. You can do what's called a bone scan, and basically what a bone scan is, it's almost become an obsolete test in today's medicine because it's an expensive test. It takes a while to get the results. Basically what you do is you take an image of the bone. That top picture is actually a picture of a bone scan. And you give someone what's called technetium, which is basically an isotope, and you take a picture of their body at 1, 3, and then 24 hours later to see where that isotope localizes. Bone scans are great tests because they're very sensitive. They pick up a lot, but they're not specific, meaning that if you see increased uptake in the knee, like in this patient, you don't know what that really means. You just know there's something going on there. So we don't do a lot of bone scans, and really CAT scans or CT scans are less commonly used for this as well. A lot of that has to do with radiation. Really, from my point of view, it's not as good a test as an MRI, which we've obviously all heard of. And this is an MRI of someone, these are bilateral tibias, and you can see the difference on the left compared to the right. On the left, you see all this edema. This is what's called a T2 image. And so this is what a stress fracture would look like on an MRI. You see all this like bony bruising and edema. And the reality is with how accessible MRIs are, how much less expensive they are now, and quite honestly, the medical legal aspect of it, we get MRIs at a much lower threshold and much more commonly now than we used to. Any questions about that at all? It's fascinating. All right, good. All right. I'm going to go through a few different common stress fractures that we see, and the reason I want to do that is because I think it's important to kind of leave here understanding that a stress fracture isn't a stress fracture isn't a stress fracture. They're different, and where they are and what the setting is can be the difference between putting someone in a cast or even having them walk on it and surgery sometimes. So I think going through that is something that can be helpful. And the first one I want to talk about is what's called a femoral neck stress fracture. The femoral neck is basically the area up by your hip right below the ball of the ball and socket. If you can imagine your hip being a ball and socket, the neck would be right where my wrist is. And femoral neck stress fractures are one of the scary ones to me and ones that you don't want to miss because of the repercussions if you do miss it. They're first described in military recruits. And generally speaking, the presentation is going to be either a runner I'm much more worried about it generally in females with a complaint of groin pain, pain in the groin area, anterior thigh pain, or knee pain is actually the other one where I'll always keep in mind. Someone with a complaint of knee pain but a normal exam and something doesn't fit, I'll actually examine the hip looking for evidence of a stress fracture at the femoral neck. The pain is generally exacerbated with walking or weight bearing. They may have limitation of motion, specifically what's called internal rotation of the hip. And rarely they're going to have pain with actually pressing. And in my practice, if this thought crosses my mind in someone, it's there until I prove that it's not. So I almost always will have a low threshold to pull the trigger on an MRI because the repercussions of missing an injury like this are bad. And if you're not going to see it on an x-ray for 2 to 4 weeks, like I mentioned before, you can't wait or you shouldn't wait. So generally speaking, we'll image these sooner rather than later. Like I said, x-rays won't show a stress fracture for anywhere from 2 to 4 weeks. Sometimes we'll get a bone scan, but as I divulged earlier, we rarely get these. Much more commonly, we'll get an MRI. And you can see on this MRI, see the left hip here compared to the right, how there's all this bony fluid on this T2 image. T2 means everything is black except for fluid. So this is the bladder, and that's the stress fracture. Can you guys see the difference there? So generally speaking, we have a low threshold to image these. And the reason why I am so diligent about looking for these is that rarely the treatment for these can be surgical. If the fracture is on what we call the tension side of the bone or the top part up here, we'll generally fix it. And the reason is it's an unstable injury. If you weight bear, it can displace. And a displaced fracture in this part of the body in a young person is, for lack of a better word, it's a catastrophe. It requires a hip replacement. It's a bad problem. So usually what we'll do is we'll put 3 little screws in to sort of stabilize the bone. But what's interesting is if you take the same little crack and instead of being up here on that top part, it's on what's called the medial or the compression side, you can actually treat it non-surgically with limited weight bearing, generally for about 4 to 6 weeks and then progress from there. So that's why it's so important. Questions about that at all? No? All right. I'm sorry? Often, thankfully, no, but do I see it do I see it on each year? Yeah. Fortunately, I can tell you that the last time I actually had to operate on someone for this was about 4 years ago. But I will tell you that I have such a low threshold to image it that I feel like I'm usually looking for it more than and more often getting normal studies than the other way around. I think that's the way it should be. But the answer is no. This is not hugely common. Not as common as some of the other things we're about to talk about. Very briefly, you can get a stress fracture of the femur or the thigh bone. It's actually relatively rare, and it's most commonly going to be in the junction of what we call the proximal and middle third. So actually right in this area right here. Strangely enough, I've seen this maybe 2 or 3 times in the last 10 years. And I saw a patient about 2 weeks ago who came with one of these. And generally speaking, the treatment is going to be non-operative. Again, it's much more commonly in females. There's something out there that's called the female athlete triad, which is actually a combination of disordered eating, loss of menstrual periods, and osteoporosis. Usually you're going to see this most commonly, at least in females, somewhere between 13 and 18. So I usually ask questions about eating habits and believe it or not, menstrual periods. And if you can believe an orthopedic surgeon would ask that. But I think it's relevant. And this is one of those things that if you don't look for it, you're never going to find it. This is not something people are going to necessarily bring up to you. But certainly when I have someone with a history of questionable eating habits, and then especially a female who's had menstrual periods and then has lost them after she actually started, that's a big red flag that they're at high risk for a stress fracture of the femur or elsewhere. And again, without boring you with the painful details, generally the treatment's going to be non-surgical, some sort of limited weight bearing, and then progression to weight bearing is tolerated depending on evidence of healing on imaging, but also pain. And in rare circumstances will you operate on these kinds of stress fractures. So rare. Shin fracture or tibia fracture is not rare. It's actually the most common kind of stress fracture that we see in athletes. You're most commonly going to see it in the back or the posterior and inner part of the tibia, generally in the middle third of the tibia. And almost always this kind of stress fracture is going to be treated non-surgically as well. Interestingly, there is something that's called the dreaded black line. This is one of those rare circumstances where an x-ray can actually show a stress fracture. And what this is an x-ray of, it's an x-ray of a tibia and fibula of a shin bone. That arrow is then magnified. And can you guys see that little line right there? It's pretty subtle, but it's definitely there. The name, they call that the dreaded black line in orthopedics, and the reason why we call it the dreaded black line is that fracture of that bone will almost never heal if you see that on an x-ray. And this is one of the rare circumstances, again, where a stress fracture will actually require surgery. We usually do what's called an intramedullary rod. What's really interesting about this is, again, you don't see this a lot, but when I was a fellow, we actually cover what's called the NFL Combine, which is where they have all the college athletes from the whole country come, and they basically examine every college athlete who might be drafted. And there was a guy who ended up being drafted, I think, second or third overall, who the team I was with didn't want to draft him because we found that on one of his x-rays, and he had kind of a funny history of having pain there and missing a game from time to time. And he actually got drafted. I don't know if he ever ended up having surgery or not, but I guess the moral of the story is you see it. But again, you got to be looking for it. In his case, he really should have surgery if he didn't to have that fracture stabilized. Fibula stress fractures. The fibula is basically the bone in the outer part of the leg. It's the outer part of the ankle, and it's actually the most common stress fracture that you'll see in runners. This is an x-ray of, I don't know how well you can see. If you look at the bottom x-ray here, this is the big bone, the tibia bone. This is the fibula, and this is what a stress fracture of the fibula will look like. Usually the treatment, again, is going to be limited weight bearing, encouraging cross-training, and then generally working up and building up muscle flexibility and strength once the fracture heals. Usually this will take about 4 to 6 weeks to heal. And then the last thing I wanted to touch on is what foot stress fractures, and obviously that's a very general word that means a lot of different things. I see stress fractures in the foot, believe it or not, probably the most commonly in my practice. Most of them are going to be treated with some period of relative rest, a cashew. Rarely will you need to actually do surgery on these fractures. The most common place where we do operate on a stress fracture of the foot is what's called the fifth metatarsal. The fifth metatarsal is basically the bone on the outer part of the foot. And if you get something called a Jones fracture, which you actually see not uncommonly in athletes who initially are diagnosed with an ankle sprain, these fractures heal better when you actually fix it with what's called a percutaneous screw. But again, operating on stress fractures are relatively rare, and where the fracture is, what the imaging looked like, will dictate what your treatment is. So enough boring you with the specific stress fractures. As far as treatment, one of the questions that I get asked a lot is, what should I take for the pain? So I diagnose you with a stress fracture, and someone says, should I take Motrin? Should I take, Advil, which is the same thing, by the way? Should I take, Aleve? And what's actually interesting is that there's definitely enough evidence out there to recommend not taking anti-inflammatory medications when you're treating someone for a stress fracture. And the reason actually goes back to basic science. When there are some guys who, work in a lab with rats, and they basically examined fracture callus, or how the bone, when new bone forms around a stress fracture, and they've given rats an anti-inflammatory and then give some not an anti-inflammatory. And what they found, not only in rat experiments, but then over and over again, is that there may be actually a poorer bone that's forming when someone's on an anti-inflammatory, whether it be Celebrex, which is a prescription-strength anti-inflammatory, or, again, Motrin, Aleve. So generally speaking, when I have someone who's healing from a fracture or healing from a stress fracture, I either recommend Tylenol, which is acetaminophen, or, if someone's having a really rough go, you can use something for pain, and I'd rather do that than give them an anti-inflammatory, any kind of non-steroidal anti-inflammatory, knowing that there's a potentially a slowing effect for healing. So that's one piece of information that I think is relevant to everyone here. And then the other question I get asked a lot is, so how do I avoid a stress fracture? How do I avoid getting one of these horrible things that you've just talked about for the last 20 minutes? Generally speaking, you start at the bottom. So you want to make sure that you have good shoes, okay? Wearing a pair of sneakers that you've had in your closet for 3 years that are all worn out and have poor support is not a great place to start. You want to make sure that your shoes generally have a wide toe box. New Balance, believe it or not, are probably among the better brands as far as types of shoe. Although obviously how everyone fits into any particular brand is going to be variable. You want to make sure that you have a good arch support. So again, it goes back to having a newer pair of sneakers. And then you always want to start slow and sort of work your way up. You've got to listen to your body. You always want to start, if you're going to start running and you're not really a runner, which is me, you always want to start on a level surface or level pavement. Believe it or not, running in the road is not level. It's what's convex, right? The road is always higher in the middle than at the sides because that's how they get the water to flow off. So if you run on the same side of the road all the time, you're actually running on a slight slant, and that can predispose you to some other problems. So if you want to start running, believe it or not, a treadmill is better to start, or a track is better to start as opposed to running in the road. And then you want to work your way up to places where it can be hillier or uneven. And you can't forget to stretch. The importance of stretching can't be understated. The fact is most people, again, myself included, do not stretch enough. And you've got to listen to your body. So if you're running and you've never run before, you probably don't want to start with a 5K and say, I'm going to run a 5K tomorrow. You've got to listen to your body and work your way up slow. And that's going to mean different things for different people. I always get questions about calcium. How much calcium? Should I take calcium? Will that prevent a stress fracture? And when you look at the literature, generally speaking, most places recommend for most healthy adults about 12,000 milligrams of calcium per day. The number goes up slightly in women who are pregnant or lactating, and it also goes up slightly in patients who are healing from a fracture, although the evidence to support this is actually pretty soft. Remember, vitamin D and calcium are synergistic. Vitamin D is the vitamin in your body that helps you absorb and process calcium. So you could take as much calcium as this, and if you don't have enough vitamin D in your diet, it's almost as if you're not taking calcium at all. So generally, we recommend about 600 units, international units of vitamin D daily, and that number of recommendation is up to 800 units if you're over 70. The reality is most people don't need to memorize these numbers or look at what they're eating because most balanced American diets actually have this in it. So that's important to know. And then I want you guys to memorize this. I think this is great to know. Thank God someone laughed. That would have been a really bad joke. Basically, all I wanted to show is that you can get calcium just about anywhere in your diet. Obviously, it's going to be most common with dairy products, with milks, with yogurts, with cheeses. But you can find it in everything from fish. A lot of fruits and vegetables will have a lot of calcium in it. If you drink orange juice or most juices that you buy in the supermarket, a lot of them are fortified or have calcium and vitamin D added to them. So this really shouldn't be something that you have to buy a pill for to take, unless you have a special diet that's very restricted. You're really going to meet these requirements by just eating normally. Questions about that? All right, so now I'm going to stop talking for at least a minute and have Gary expand on this just a little bit. Do you want to take that? You got a couple slides. Sure.
Okay, so physical therapy, one thing I wanted to talk about first was what's our goal for physical therapy? We're looking at soft tissue restrictions, joint restrictions, movement restrictions. We're looking for muscle weaknesses, muscle imbalances. If you think of the muscles as guy wires and you have one muscle on one side that's real tight and one on the other side of a joint that's not so tight, it's going to cause pressure on that joint. So those are some of the things that we're looking for in physical therapy. As I progress through my treatments, they're going to sound pretty similar because we're doing the same thing, but we're addressing these dysfunctions. So what we're trying to do is keep the athlete strong and fit while healing the injury. Another goal that we're doing is we're trying to accelerate the healing process with physical therapy, and there's a lot of agents that we can use to help do that. So we're looking to do low-impact cardio, self-stretches to tighten and flexible muscles, upper extremity strengthening cardio, and swimming. Assessment and treatment of muscular imbalances, we're going to look at muscle length, flexibility, and strength of surrounding muscle, also to decrease compression and or pulling on the adjacent tissue. That's what I was talking about with the muscle imbalances. We'll also do a gait assessment. We're going to assess the foot and ankle for proper alignment and mechanics of the gait. We're going to actually have the patient walk away from us and towards us, and we're going to look at the mechanics. We're going to look for a functional dysfunction or a structural dysfunction, and we treat those a little differently. Again, what Dr. Sileo had mentioned, footwear. The footwear can be improved through proper impact absorption. Typically in the heel is where people strike in stance phase. And this breaks down, this cushioning breaks down pretty quick in the sneakers that you wear. So you want to keep up on that. If you're out there running all the time, you probably want to change your sneakers out after about 3 months or so. Treatment, stretching tight muscle groups, strengthening weak muscle groups, soft tissue mobilization, myofascial release to the muscles that present with myofascial dysfunction. You'll see a lot of acronyms there. So the STM is soft tissue mobilization, MFR, myofascial release. These are basically massage techniques that we do. This is you. All right. Okay.
All right. Any questions about that? Yeah.
Question.
Sure.
When is the best time to stretch? Is it pre-exercise, post?
There's not a lot of strong evidence to say that you should do both or one over another. I generally recommend that people stretch afterwards. You could find actual studies that support both ways, that say you should stretch both before and after, that you need to stretch before, and there's a lower incidence of injury if you stretch before. You'll find studies that show that it's better if you stretch after and that you reduce the risk of injury after. And I think you can twist the basic science behind it to support either or. Generally speaking, it makes more sense to me that you stretch after, that you warm up first for 5 or 10 minutes, then exercise and then stretch. And the reason why I say that is, the muscle has blood flow. It's been active, and that's the best time to stretch. If you stretch a cold muscle or you stretch a muscle that hasn't been used, you're at higher risk for tearing fibers or injuring it. But certainly you can find someone who will tell you the exact opposite.
I wouldn't say the exact opposite of that, but I've just finished up some warm-ups and stretching activities and did a lot of research in this. If you do a stretch before, it should be a very light stretch. Very light stretch, then go do your exercise. That's where you're going to warm up that muscle, and that muscle is going to be much more extensible, a lot more flexible after the warm-up. And then you do the majority of your stretch after the treatment. If you do it prior, the muscle is going to be colder, so very light stretch.
All right, so the next topic we're going to touch on is something called patellar tendinopathy or patellar tendinitis. I got some cool pictures. Basically, this is your classic jumper's knee. You're going to see this in athletes that are participating in more jumping sports, volleyball, basketball, less commonly in runners per se. And generally, your exam is going to show tenderness at the patellar tendon, right? There's not a lot of science behind that part. It's most commonly going to be at what's called the inferior pole of the patella, or basically where the tendon attaches to the kneecap. And what's interesting about this to me is, and this is not an attempt to try to be all scientific, but basically what you have with a tendinopathy is you have something that's called angiofibroblastic degeneration. Big word. It actually means something very simple. This picture is what tendon looks like under a microscope normally, right? It's like kind of organized. It's in a line. It looks very symmetric. What happens with tendinopathy is what we think happens is it's basically when you get micro injury to the tendon, whether it be from overuse, a strain, whatever it may be, and your body tries to heal that area of tendon. And so it starts to increase blood flow there, but the initial tissue that it forms is very disorganized. It's very, it looks clearly different from here. And when you don't give the body or you don't give this tissue time to rest, heal, and reorganize, this is what it looks like under a microscope. And believe it or not, I'll show you some pictures a little bit later. You can see changes on an MRI too that show that this is going on as well. And what happens is that if you don't give, again, the body a chance to let this area heal, reorganize, and become proper tissue, you can have kind of these chronic long-term symptoms from something as simple as a quote-unquote tendinitis. Generally, the treatment for a patellar tendinopathy is obviously conservative. So it's activity modification, ice. In this particular case, anti-inflammatory medications, whether it be an over-the-counter medication like Advil or Naproxen, is definitely recommended. I usually use a medicine called meloxicam, which is a prescription-strength anti-inflammatory because it's safe, it's gentle on the stomach, and it's once a day. So I find it's easy to get people to take something once a day. Anything more than that is always a crapshoot. Keep hitting the wrong button. Therapy can definitely expedite the recovery, and we'll talk a little bit about that. A counterforce strap can be very helpful for this problem. Initially, you want to focus on quad stretching, isometric and what are called short arc exercises, and then you progress to something called eccentric strengthening. Basically what eccentric exercise is an exercise where you're contracting the muscle, but it's lengthening at the same time, right? So if I'm doing a bicep curl, if I'm grabbing a weight and I contract my arm, this is called concentric exercise. I'm lifting something up. Eccentric exercise would be taking that same weight, starting from here, but going straight. And believe it or not, there's a lot of evidence that eccentric exercise can not only help tendinopathy heal more quickly, but it actually can help you build muscle strength and bulk more quickly than concentric exercise. But that's what eccentric means. There are rare circumstances where we'll operate on patients with chronic recalcitrant patellar tendinopathy. If I do this twice a year, it's a lot. And obviously, if the tendon ruptures, that's something we generally fix.
Man, got to use these glasses all the time now. Okay, so patella tendinitis. What we want the patient to do is rest, ice, heal, and then progress your exercises slowly. A lot of this happens, it's an overuse injury. The person's going out there, they're doing too much, too fast. Some of the treatments that we do, ultrasound, which is a deep heat modality, we want to heat up that tendon and get it more extensible before we start doing our soft tissue mobilization. CFM, that's cross-friction mobilization. So it's another soft tissue technique, but we're cross-frictioning that. We're actually perpendicular to the fibers, and we're breaking up some of that collagen that you saw in one of those pictures there. So instead of having striated tissue formation, you'll have this matrix of collagen that's been laid down. So cross-friction will help break that up and get that tendon to move the way it should. Soft tissue mobilization, myofascial release. We actually use Graston technique here at the lab. Graston technique, these are stainless steel bars that assist us with soft tissue mobilization, and the patients love it. Right, Pat? So we'll do that to the distal quads if tight, stretching the quads and hip flexors, and any other muscle groups that we've identified as being tight. Also progress to light quad eccentrics, which Dr. Sileo just had mentioned, and so we're going to slowly increase sets, reps, resistance, and then we're always going to ice afterwards to decrease any inflammation that we may have created in the process of treatment. All right.
The next quick topic is something called ITB, or iliotibial band syndrome. It's definitely easier to say ITB syndrome. Your iliotibial band, if you look, this is the side of a thigh, this is the butt, this is the front, the head would be up here, feet would be down here. Your iliotibial band is actually a sleeve of connective tissue that runs from the musculature that attaches up here by what's called the iliac crest and comes down the lateral or the outer part of the thigh. And then it comes down past the knee and attaches on this little bony bump down below the knee that's called Gerdy's tubercle. So it's just this connective sleeve that we all have on the outer part of the thigh. And ITB syndrome is actually the most common cause of lateral or outside knee pain in long-distance runners. And the reason why runners get this is that there's friction between this ITB, or this connective tissue, and a little tiny bony bump that we all have on the outer part of the femur or the thigh bone that's called the lateral femoral, it's really the epicondyle. Generally, the pain is going to be worse at 30 degrees of knee flexion, meaning just short of fully straight. You see it most commonly in runners that run in hilly areas. I see this all the time. You know when I see this the most is like right around September, October, every year when people are training for the marathon. And it's like, it's unbelievable how many patients who are runners with knee pain with no injury I see, and it ends up being this, especially in people who are training for their first marathon. Generally, on exam, you're going to find tenderness to palpation just above the actual joint itself, and patients will have a positive Ober's test. Ober's test is a test we do in the office to check for tightness of that iliotibial band or connective tissue. And what's interesting and what's sort of the tip-off to me is that patients usually say, I'm fine. I'm totally fine. And then I start to run and I'm fine. And then like 2 miles in, 3 miles in, it starts to hurt me and it just won't go away. And I feel like if I keep running, it'll go away, and it doesn't. And then, when it gets really bad, usually when they come to see me, it's because they now can't run. They stop. They're like, I can't do this anymore. And then when they rest, by the way, the pain goes away. When they stop running, they're like, I'm totally fine again. Nothing's wrong with me. treatment for ITB syndrome is, again, going to generally be non-surgical. You want to evaluate, how someone's running, where they're running, how far and how frequent they're running. You want to adjust the entire kinetic chain, stretch out that ITB. The TFL stands for tensa fascia lata. That's the muscle that the ITB attaches to. You may want to consider subtle things such as adjusting the height of the seat in cyclists, or orthotics for those patients that have pronated or flat foot. Generally speaking, modalities such as ultrasound, stim, iontophoresis, which Gary will talk a little bit about, can be very helpful for this. Anti-inflammatory medicines are helpful. I'll be honest, I give cortisone shots out for this a lot because it just works, especially 2, 3, and 4 weeks before the marathon where someone's been training really hard for a long time. I mean, I've had people crying in my office because they're like, I can't believe I'm not going to be able to run. You give them a shot, and then like 2 days later they call you, and they're just so happy that it's better. And the fact is, cortisone, it can help a lot, and it can help very, very quickly in someone who doesn't have the time to go through the more prolonged treatment course. Rarely we do surgery for this, although there is an operation that we do. It's called a Z lengthening. Basically what you do, if you're looking at the outer part of the thigh, and this is the ITB or the iliotibial band, we'll basically cut like a Z in it, and then we lengthen it. So we cut the Z, let it spread out, and then suture it back together, lengthened out. And what you're basically doing is surgically you're correcting something that in most people, if they just stretch and get the treatment that they need, they'll do on their own. But we don't do this an awful lot. Again, for me, once or twice a year would probably be a lot, to be honest with you. So it's pretty rare. And then PT.
All right. So you saw that Z procedure. What we're trying to do here in PT is try to lengthen that iliotibial band so that you don't have to have the surgery, and not trying to take business away from you. So we're looking to do moist heat, ultrasound to that distal area of the IT band, soft tissue mobilization, myofascial release at the tensor fascia lata. Graston technique works really well on the iliotibial band. And in some cases, the quadriceps will do the same type of techniques. Definitely want to stretch the quads, the IT band, the hamstrings, and one of the external rotators of the hip, the piriformis muscles. We'll send the patient home with a home exercise program, a foam roll and self-stretches. What really works well with this before you do the stretches, and really any lower extremity stretching, is if you have a hot tub, get in that hot tub for about 15 to 20 minutes, warm up those legs, those muscles really good, and you will stretch a lot better than if you had tried stretching cold. If you don't have a hot tub, then get in a hot bath, and that'll help warm up the muscles as well. After that, you want to rest and ice afterwards. We want to do cardio to stay conditioned and pain-free. So, if you're stuck there with that injury and you're not out running like you'd like to be, there's still a lot of other exercises you can do to keep that cardio level high. So you can get on the recumbent bike. We have a seated elliptical, which is going to train both the upper and lower extremities. And swimming is a really good exercise. It's non-weight bearing, and you'll use really every muscle in your body while you're doing that. And don't forget about the upper extremities. You can condition yourself by strengthening and doing cardio work with the upper extremities as well. All right.
Questions so far? All right. The other thing I really wanted to talk about, this is kind of like the last big topic, is the overuse syndromes of the leg. And when I say leg, I mean the area between the knee and the ankle. Basically, your leg is comprised of your two bones, right? The tibia and fibula, and those two bones are attached at the top and at the bottom, and then they're attached in the middle by something called the interosseous membrane. It's basically this connective tissue that keeps those bones in proper relation together. And if you look at the leg in cross-section, and this is not a gory picture, but it's like an artist's rendition. What I basically want you to take away from this is that there are like sections to your leg. We call them compartments. There are 4 compartments. And basically these compartments have different muscles and different nerves and different arteries in them. And this will, why I'm telling you all this, we'll come back in a minute. When you talk about shin splints, or the medical word is medial tibial stress syndrome, it's basically sort of, to me at least, a sort of wastebasket diagnosis that's used to describe any pain in the lower leg that's not related to a stress fracture, or it's not related to something called ischemia or decreased blood flow. And the AMA, the American Medical Association, basically defines shin splints as any discomfort in the legs from repetitive running on a hard surface or forceful, excessive use of the foot flexors. Who do we see shin splints in? You see it in a guy like this who's initiating training. But you also, untrained individuals who are starting to train. This guy's still too. But you will see it, and actually I would tell you I more commonly see it in someone like this who's a trained person, clearly a fit and active person, but they're changing their workout, they're changing their regimen in some way, whether they're training for a particular event or just changing the way that they want to exercise. You're most commonly going to see it in the front part of the leg. We call it the anterior compartment as opposed to the back. And generally speaking, it's an aching kind of pain that's exacerbated with running and walking. When it gets really bad, it'll bother you with daily activity. And the causes for shin splints are variable. You're starting to see sort of a recurring theme here as far as what we see. Again, poorly worn shoes or running on hard surfaces can be the culprit. Asymmetry in the musculature, whether it be from weakness or inflexibility. Patients who have pronated or, again, flat feet can be more prone to shin splints. Heel eversion, or actually a curve in the tibia bone, we call it tibial vera. And then again, training errors can predispose you to this kind of problem. The treatment for shin splints is rest, right? We all kind of know that it's going to be some form of rest. The question is, what else can you do? Most people, it's about an average of 8 days before they get better. Ice can be helpful, anti-inflammatory medications, resistive exercises once the pain is better, stretching of not just the muscle that's affected, but what's called the antagonistic muscle, or the other muscle that provides the opposite movement in that part of the body. And then you want to review, not just your shoe wear, but your training regimen, where you're running, how well your shoes are cushioned, all that kind of general stuff. What's really more interesting to someone like me is something that's called an exertional compartment syndrome. And again, if you look at the leg, there's 4 compartments. There's what's called the deep posterior, the superficial posterior, the anterior, and the lateral compartment. And what happens is, and anyone who's exercised this knows, when you exercise or when you lift weights, your muscles actually swell a little bit from the increased blood flow that you're asking, from the extra work that you're asking those muscles to do. But as I said before, there's actually these sections or compartments in the leg, and these sections actually don't allow for a whole lot of swelling in most people. So what actually can happen is that as your muscles enlarge with increased demand that's put on them, especially in runners, sometimes, in rare circumstances, the increased amount of blood flow can actually start to squeeze the body's ability to actually get blood into that same area. And the name for this is an exertional compartment syndrome. And what you'll actually find is that this is, again, a history diagnosis more than anything. And I actually see this not infrequently. Patients will have exercise-related pain. It's almost not always located in the lower leg, so again, between the knee and the ankle, most commonly in the anterior, the front part of the leg. Although it can happen just about anywhere. And it's the history that gives it away. The common story I hear is, I've always been a big runner. I love to run. I run, 25 miles or some number that boggles my mind that anyone can run in a regular week. And they'll say, but it's the same thing. It's always 8 minutes in, 10 minutes in, 12 minutes in. I start to get it doesn't hurt, but it kind of cramps. It feels like a cramping. And then it doesn't go away and I have to stop. And within 5 or 10 minutes of stopping, the pain goes away. And when I start to run again, 8 minutes, 10 minutes, 12 minutes in, it starts to cramp. Some people will actually complain that they'll get a little numbness in the foot depending on where this process is happening, depending on what nerve is affected. And it's most commonly in both legs. And the reality is when I see these people and examine them, their exam is completely normal. Their pulses are normal. Their strength is normal. When I x-ray them, their x-rays are normal. If you get an MRI, that's going to be normal. But really, when you need to examine these people is after they exercise. I actually have a college kid coming in tomorrow after office hours who I think has this, and we're going to put him outside and make him run. And usually what we'll do is we'll do something called a compartment pressure measurement. And what that basically is, it's basically when we put a tiny needle, it's tiny. Depends on what side of the needle I guess you're on, but it's a tiny needle, and we actually will have the athlete exercise until they say that they feel the symptoms that they're complaining of. And then we'll measure the pressure in the compartment. Depending on where you think this is, you may have to measure all 4 compartments. And then we have all sorts of criteria that we use for what designates an exertional compartment syndrome. This is one of those rare overuse syndromes where, generally speaking, the treatment's going to be surgical, actually. And the reason is that shin splints or non-ischemic problems are generally very responsive to conservative treatment. But when you talk about someone with a true exertional compartment syndrome, the literature shows that the results of non-surgical treatment are actually poor. So usually what we'll do is we'll release those little compartments to make more space. Sure. Can it? It can, but the answer is it depends. I mean, the reality is that when you're talking about a shin splint, you're talking about an overuse inflammation of the periosteum or the musculature, right? So it's an overuse phenomenon. A stress fracture is when you have someone who's overused it to the point that the bone actually fatigues. So to me, they're different entities, but they're on the same spectrum of what's causing the problem, which is overuse. But to me, a shin splint is not a precursor necessarily for a stress fracture. It's a different entity, so to speak, if that makes sense. Maybe. So in other words, if you were diagnosed with a shin splint, it doesn't mean if you keep running, you're definitely going to get a stress fracture. But usually the causative factor that's causing the shin splint is the same kind of thing that can cause a stress fracture in the proper setting with all the factors being, aligned properly. But they're not one and the same. I'm trying to speed it up.
Okay, so this is an overuse injury, so we want to let the patient know, educate them that this is overuse, and we want to decrease the amount of activity that they're doing. We're going to do soft tissue mobilization, myofascial release, and Graston technique to these muscles that have tightened up. We want to loosen those muscles and make them flexible again. So we're going to do stretching the muscles of that compartment, kinesiotaping to inhibit the muscle group if it's the superficial anterior muscle group or the superficial posterior group. And then rest and ice. We don't want to overuse these muscles and make it worse, so there's going to be a lot of rest involved. Okay.
And again, for that exertional compartment syndrome, generally speaking, the treatment, this is one of those rare circumstances where the treatment is surgical, and we'll actually release each of those 4 compartments to make more space for the muscles to work properly. Last topic, I swear, then I'll leave a few minutes for questions, is Achilles tendonitis. It's actually the most common form of tendinopathy or tendonitis. Generally, patients will have tenderness above where the Achilles inserts on the calcaneus. It's almost always 3 to 5 centimeters above where the tendon inserts. And again, predisposing factors can range from valgus heel, which is sort of along the spectrum of pronation or what we call pes planus, flat foot, to a tight gastrosoleus complex. Generally speaking, with Achilles tendinopathy, you want to determine the athlete's training history, get an idea of what kind of setting they're running in. Again, these are the same kind of things we're going to find out as far as the history and exam to determine what's going on. Imaging can be performed either with ultrasound. Most commonly, we'll use MRI, and you can actually see tendinopathy on an MRI. A healthy tendon on an MRI, no matter what type of sequence we use, is generally black and solid. And as you come up the Achilles tendon here, you can start to see this area right here where the tendon is edematous, and it's actually swollen. And this is what tendinopathy will look like on an MRI, whether it's the Achilles or elsewhere. The treatment for Achilles tendonitis is again, going to generally be some form of rest, ice, modalities, whether it's ultrasound, stim, iontophoresis, anti-inflammatory medications. Usually we'll start with stretching, and then when the pain decreases, then we'll start to progress to strengthening exercises. Athletes can return to sport when the tenderness to palpation is gone, and also when they have full range of motion and strength. Sometimes I'll let them go back to sport with a heel lift that will gradually wean them off of, and the importance of maintenance stretching for this kind of problem can't be understated. As far as interesting stuff, there's actually been a couple studies out, and I've been using this. You guys have heard of nitroglycerin patches, like the same thing that they give people when you're having a heart attack, chest pain? Nitroglycerin is actually a vasodilator, and there's actually evidence out there, and I've used this on a couple family members and about maybe 24 patients who have had recalcitrant Achilles tendinopathy. They've had this for 6 months, a year, 2 years. They've gone to PT, they've done medicines, they've done stretching, they're done with all this, and they just don't know why it keeps hurting. And what you can actually do is take a nitroglycerin patch, cut it into quadrants or 4s, and put it on the skin right over the area of the Achilles tendonitis. And what we think it actually does is it increases blood flow into that area of tendon that's just not healing on its own. You got to be careful. Patients who have a cardiac history, obviously you don't want to give them something like this. And the most common side effect that I've seen is headache, which you'll see with nitroglycerin patches for any type. But what's interesting is I've been really, really excited by how well this seems to work. So it's just a new form of treatment out there that we've been using that it provides promise. Rarely will you do surgery on this. This is actually a picture of an Achilles rupture. But rarely will you actually operate on Achilles tendinopathy. When you do, it's either because the tendon has ruptured or someone has truly failed a 3 to 6 month, probably closer to 6 month course of conservative treatment, and they're still struggling.
I believe this is my last slide here. So Dr. Sileo really went over all the stuff that we do in physical therapy with the stretching and heating and all that stuff. The first thing we want to do is look for any mechanical disorders of the foot. Gait training if needed. If we find a structural deficit in the foot, we'll mobilize the metatarsals and the cuneiforms. If it's a functional deficit, we'll do gait training with the patient. We'll observe their gait and watch and educate the patient on how to correct that gait disorder. We do ultrasound, sometimes moist heat as well. This is to bring blood into the area. Soft tissue mobilization, myofascial release, and cross-friction massage on this as well. That will help break up some collagen deposits in the area and also bring blood flow into this area. Stretching of the gastroc, soleus, and tendon. Kinesio tape to inhibit the gastroc and soleus and just take some of the pressure off the tendon. It's a very light but effective treatment. Also rest and ice. And then we want to progress to heel raises with emphasis on the eccentrics. Balance, we're going to work on balance, coordination of all the muscle groups around the ankle, the knee, and the hip. And I believe that is it. Did you want to go over this?
Yeah, I actually just put this slide in, but I kind of went over it already just because I realize sometimes we throw terms around like eccentric exercise and I don't explain what it is. This is an example of a classic eccentric exercise. You take an athlete, put them on the edge of something preferably low to the floor, and then you have them go from a toe-up position, and going from the toe-up position with the gastroc muscle contracting, asking them to go down until their foot is in dorsiflexion or up. That's eccentric strengthening, and it's the same thing I was describing before with the biceps, having a weight but going from a flexed to a straight position. And eccentric exercising is generally one of the classic types of exercise that generally we use for the treatment of Achilles tendinopathy. So I wanted to make sure everyone understood that. And then I'm a big fan of bottom line slides because after an hour, you're probably numb to what we're saying. The bottom line today is we can't stress enough the importance of proper shoe wear, gradual increase in activity. You want to progress, if you're a runner, from flat surfaces to more hilly terrain, the importance of stretching we touched upon. Again, in the right setting. Outside of stress fractures, NSAIDs can be hugely helpful. The benefit of therapy and intermittent cross-training, and you got to listen to your body. Your body doesn't lie. So that's kind of the gist of this whole talk. And this is my attempt at being funny again. I don't know if this is real or not, but I saw this somewhere, so looks real. Any questions at all?
Any injuries coming from people using like barefoot or minimalist running shoes?
I actually haven't. You mean like the toe, like the yeah? Interesting. That's a good question. The answer is no, I haven't. And I don't know if it's just because I haven't seen it or if it's just not really happening out there. My guess is, honestly, is that if you're wearing those kinds of shoes, you're not really doing the type of truly long distance running enough to see some of these things. But the answer is no. I don't know if you have.
I've actually seen that. If you look at your ankle works as a shock absorber, okay? If you use the same gait mechanics that you would running as if you were wearing shoes, you're going to go about 30 feet and then stop what you're doing because basically you're slamming, you're making heel contact when you run with sneakers on. When you run barefoot, you can't run like that anymore. You actually have to use that shock absorbing effect that the ankle provides. So you're actually landing on your forefoot. You're using that built-in shock absorption as your absorber, as opposed to the neoprene, or the soft cellular shock absorbing, the
So would that be a better idea if you could do that with those foot gloves?
What I would say is start out running short distances and get a feel for that. Definitely, you're not going to do heel contact, midfoot, and then push off through your toes. You're going to be landing on your forefoot. Get that shock absorption from basically the ankle and the gastroc soleus complex, and then you got to progress your run.
Does anyone here remember that Seinfeld? Am I like showing my age by talking about Seinfeld? No. Remember that episode where like George was selling those like sneakers, like the jumping sneakers, right? With like that big platform on the front where you're walking on your toes. That to me is like, in my mind, that's kind of like what those other shoes are. It's basically you're training yourself to run more on your forefoot and use the muscles to absorb. And I can't picture being able to run long distances, a couple miles, 3 miles, 4 miles in those shoes, because that's not really what they're designed to be able to do. And Gary is dead right, is when you run and you run long distance, you're striking with your heel. When you're running with those shoes from that episode, or if you're running with those like, minimalist shoes, you're really going to be running way more on the forefoot. And I don't think that's going to be the way that you're going to. If that was the way to run long distances, then every guy who wins the marathon every year would be wearing those, and that's not what you see. So I think it's almost like you're training for a different kind of activity.
You're going to use your calf muscle a lot more when you're running barefoot or using those barefoot shoes, because that's what's providing the cushioning and the shock absorption. Yes.
I think the toe to heel is more restricted like that.
Yeah, I agree. He said that toe to heel running is more restricting. So those minimalist shoes or those minimal shock absorbing shoes, it's think about it. When you sprint, you're running like that. You're running on your forefoot basically. When you're doing these longer distance runs, you gotta use your heel strike to sort of help absorb some of the blow. So I agree. And this is not coming from a guy who does a whole lot of long distance running. I mean, I don't know if someone else does.
Any other questions?
Yes.
Topic back to the knee. Osgood Schlatter.
Yeah.
Tell me about that.
Yeah. It's not going to affect anyone in this room. Osgood Schlatter is basically what's called an apophysitis. You'll usually see it more commonly in boys than in girls, and usually you're going to see it in kids somewhere between 8 and 13, 8 and 14. What it basically is the little bump in the front of your shin where your patella tendon inserts on is called a tibial tubercle. It's the name of the bump. And in kids, when they're still growing, there's a growth plate there. And so what you'll see is in a lot of, again, boys more than girls who play a lot of sports, who are, always running around playing basketball, volleyball, soccer, whatever it is, they'll actually start to get some inflammation of that growth plate, and it can be pretty uncomfortable, actually. And it's basically an overuse phenomenon that's relegated to the growth plate. That growth plate usually goes away somewhere between 14 and 16 years old. So rarely will you see adults that have long-term problems from Osgood Schlatter specifically. I will see a patient occasionally who will have a prominent tubercle that's more prominent than the average person because when they had that problem as a kid, they developed more bone in that area. But it's rarely something that you'll see in an adult population. And the treatment for that, by the way, is going to be along the same lines. It's almost always rest, which telling a 12-year-old to rest, I mean, it's easy for me to say because then I go home. But, when you're with the parents and you're like, all right, tell them to rest for 6 weeks. Okay. It's hard, and we realize it's hard. The fact is it's pretty rare that you're going to do long-term damage by playing through it or just dealing with it. And I think that's what most people end up doing if you want to be realistic about it. Yes, I mean, Sievers is basically the same spectrum of an Osgood Schlatter. So in the calcaneus, at the apophysis, which is basically the back part of the heel where the Achilles attaches, there's a growth plate there as well. Usually you'll see Sievers. It's actually interesting, like these apophysitis problems, they're like very age-specific, and they kind of go through a progression. Sievers you usually see in that 7 to 8 to 10 kind of range, years old. And then for whatever reason, when kids get a little older, it becomes much less common, probably because that growth plate starts to close. But it's the same thing. It's almost like the kid variant of an Achilles tendonitis, basically. Kids, generally speaking, or at least adolescents who are still growing, their growth plates are usually weaker than their ligaments and weaker than their tendons. So you're not going to see an Achilles tendonitis in a 10-year-old. You're going to see severs. You're not going to see an ankle sprain in a 12-year-old. You're going to much more likely see a growth plate problem. So it's almost kids are not small adults. There's a different set of problems that you see in patients who are still growing. But the treatment is, again, it's the same type of process. It's relative rest, it's Motrin, it's sometimes heel lifts. I'm a big believer in therapy. I think that if you just tell someone to rest, it's hard to get them to do that. If you tell them to rest, but we're also going to do something to address the inflexibility, we're going to do something to keep you active but treat the inflammation, people respond, or patients respond better to that, generally speaking. I usually don't tell patients just to play through it. I'll usually recommend rest. But I'm also realistic. I know that once they leave, a kid is going to do what they feel they can do, and if it hurts, they're not going to do it, right? So I usually will say, listen, if you want it to get better, you got to rest it for 4 to 6 weeks. That's what's going to make it get better. If you play through it, you're not likely to make it worse, but there's always that possibility you're rolling the dice. And that's my way of sort of covering myself. Yeah. Awesome. Thanks for coming, guys.